Evening. I'm not sure. Thank you, Carl, for those introductions and for teeing us up with the sustainability criteria. So I hope we will be able to hit those. I'm going to try and cover 3 project models. So I'm very glad that Gloria was able to open with some stories, because I'm afraid I won't be able to share too many stories with you, but just do the overview of these project models. So just to give you a quick idea, World Vision has had our HIV program for over 6 years, which we call the HOPE Initiative. So I'll be sharing the goal, target groups and project models that have come from the HOPE Initiative, as well as an overview of 3 project models, just a taste of some research related to those project models, and a quick reflection on some lessons learned and challenges and next steps related to those project models. So our goal is quite simple about the reduction of the impact of HIV and AIDS on children. We have 3 objectives around prevention, care, and advocacy. So for prevention, we want to contribute to reduction of risk and vulnerability to new HIV infections. With care, we want to protect and improve the well-being of children affected by HIV as well as their households. And for advocacy, we want to promote policies and practices that reduce stigma and discrimination and uphold the rights of children and adults affected by HIV. So how does that break down into project models for us? For the care model, we really have developed an approach to building community-led care for orphans and vulnerable children, which is called Community Care Coalitions. So I'll be unpacking that a bit. With faith-based institutions, we have worked with the church, CABSA, which is the Christian AIDS Bureau of Southern Africa. They have developed a methodology called Channels of Hope, which they still have the copyright for, but we have a memorandum of understanding to co-develop and use Channels of Hope to mobilize faith-based communities around HIV. And for our child-focused expanded prevention model, one piece of that, one project model within that overall expanded prevention approach is community change, or C-Change. So starting with community care coalitions, or CCCs as we affectionately call them, it's really about a process of bringing together community stakeholders around care for vulnerable children in the community. And so it's basically a group of people that come from different agencies and institutions, individuals in the community that are concerned about vulnerable children, and they come together to coordinate and provide a holistic response to HIV, particularly around the needs of vulnerable children and their households. So we start with the member organizations, and really these are the ones that are interested or already engaged and involved. So they could be churches and faith-based organizations, schools, various care groups, other community-based organizations or non-governmental organizations in that community, as well as technical representatives from the government or political and opinion leaders, and other sources of support coming from other NGOs, CBOs, or perhaps the private sector. So basically, these groups are led through a process of identifying the needs in their community, coming up with a plan for what they will do to address those needs, and eventually identifying home visitors that can be trained around the needs of children, so health, education needs, the psychosocial needs of children, protection, and be able to work with the Community Care Coalition to identify who are the vulnerable children in the community, and then begin to provide support by making regular visits to households to check on how those children are doing and to address the needs that they find working with other stakeholders in the community. So that essentially leads to those reaching those vulnerable children and providing support to both them and their caretakers in the household. Just a quick piece of research, we have had a longitudinal quasi-experimental study in Zambia and Uganda that has gone on for the last 4 years, looking at, starting with intervention communities and comparing them to a set of comparison communities, and then eventually rolling out the interventions to those comparison communities and checking on a variety of indices. With this particular slide, we're looking at access to adequate food. And that was measured by looking at, with those children in the last 30 days, did they have access to, had they reduced the amount of food that they had available? Had they skipped a meal? Or had they gone for a whole day without eating because they didn't have adequate food or money to buy food? And so what we saw in both Zambia and Uganda was a statistically significant increase in the number of children who had access to adequate food. So that was very encouraging for us. I think that perhaps the discouraging thing that you might note from this slide is that still more than 50% of those children were having issues with food security and still did not have adequate access to food. So clearly we've got more work to do, even though there was a very significant increase. It's still not adequate for those vulnerable children. Some of the challenges have been how to engage all the stakeholders that are interested without offending the traditional stakeholders that think that they're in charge. How to ensure accountability for CCC members, most of whom are volunteers generally, and how to follow up with CCC facilitators, particularly when they come from other partner organizations that are working with us. And then there's the increasing impact of HIV in the communities where we work, because we've seen an increase in just the sheer numbers of vulnerable children, and that's been exacerbated by the financial crisis and the food crisis. So that's led to more children per volunteers than is really optimal. Moving on to Channels of Hope, and I'll quickly click through these process steps here. It starts with the Channels of Hope workshop where faith leaders are sensitized around the HIV and AIDS. They really address HIV and AIDS in themselves, stigma and discrimination. They go back to their communities, start to talk about HIV, and mobilize a congregational hope action team, or CHAT, and certainly they can call it something else if they'd like to. And that CHAT also goes through a similar workshop of addressing HIV beliefs and attitudes, stigma and discrimination, and then they're exposed to the needs in the communities around them, around prevention, advocacy, and care, and they come up with a plan in terms of how would they like to respond. That's often led to CHAT sending members to the Community Care Coalition and at that point engaging with the CCC and having those CHAT members be trained as home visitors within the CCC. Just a little snapshot of some change with respect to those faith leaders. So what we found is after they had gone through the Channels of Hope process, there was a real statistically significant reduction in stigma, particularly around the two issues that are highlighted there. So faith leaders went from thinking that HIV was God's punishment to disagreeing with that statement. So 42% after going through the training said, no, that's not true. We disagree with that statement, as well as very encouragingly being willing and wanting HIV positive faith leaders to be able to preach. So that went from 74 to 91%. Another study looked at the number of faith leaders who were, after participating in the Channels of Hope process, who had gone to have an HIV test. And so, again, with the study that we did, eventually the comparison villages also received the intervention. And so what you see at the final evaluation is that all of the faith leaders had gone from about 40% to 60% of faith leaders going for an HIV test in Uganda, and from very low levels in Zambia to almost 40% of those faith leaders being willing to go for an HIV test themselves. So very encouraging results. Some of the lessons, we found that it's adaptable to multiple cultural and faith contexts. We've had it translated working with CAPSA in many languages, adapted to ecumenical and Catholic environment, Russian Orthodox environment, now have worked with Muslim organizations to develop a Christian and Muslim version. And it's just taken off, so we've been able to use it globally. And the effectiveness, again, relates to the standards as well as the mentoring and coaching that's built into the process. And an exciting lesson or change for us has been the number of partner organizations that have picked this up. And so facilitators now, more than 50% of the participants are coming from partner organizations. So we really believe that sustainability is being built into these faith leaders going on and addressing HIV for the long term. Moving on to the sea change, part of our expanded prevention model. This is really about, it came out of, again, the same research that I've shared with you, that we started to see that our life skills approach really didn't produce the behavior change that was desired to address HIV. And so we realized that children, just giving life skills to children, didn't address all the stakeholders that are involved in their lives. And so we really needed a 360-degree approach of reaching that individual child, their peers, the community stakeholders and leaders, as well as the whole environment in terms of cultural norms and practices and policies and structures. What is sea change? It came out of the community conversation model that was developed by Salvation Army and UNDP and adapted and tested in Ethiopia. And it's really about having a transformational approach to address societal and cultural determinants of HIV vulnerability. It allows for a facilitated conversation with the community that starts with exploration and reflection of values and practices that underline HIV risk, including gender inequity and power imbalance. And it allows the community to learn and share through the change process, identify local resources and social capital to address those issues, and to make a decision about what they want to do with respect to HIV risk in their community. This just shows the process, but I'm starting to run out of time here. I think the real key here is it's about an inward transformational process that requires a very trained facilitator that can build trust, help the community to identify the concerns that they have, explore those concerns and dig deeper into the underlying issues that are affecting that practice. Make a decision. So a decision could be, in our community, we will no longer tolerate early marriage of our girls, and then following up with developing a simple action plan, and then actually sitting down with the community to reflect on how has the process gone and asking critical questions about what's changed in the community as a result of this process. Some of the preliminary outcomes from Ethiopia have been increased uptake of voluntary counseling and testing, reduced stigma. Very exciting to see the community develop bylaws around gender-based violence and harmful traditional practices that they've developed and distributed. It's strengthened the community care, both for children and people living with HIV, led to increased open communication, and 50 community change groups were started, and their uncircumcised girls clubs have also begun and have 835 members. Just a few lessons learned in terms, it's been very transformational and empowering for those communities in terms of their being able to lead their change process and address the norms and practices that are increasing risk of HIV in those communities. Success really depends on the facilitator, and process documentation is important. And we believe that the sea change model could be used for many other practices that relate to health, where there's generational or cultural issues in that community. I think instead of covering the next steps here, I'll just say that for us, these project models have allowed us to contextualize and to adapt the project models and to really take them to a scale that we wouldn't have been able to do without developing a project model approach. So with the CCCs, that's led to reaching 1.2 million vulnerable children in Africa, with 4,500 community care coalitions working with 78,000 volunteers, and more than half of those volunteers have come from the local churches and faith-based institutions. So I hope that we'll have some good questions and dialogue around these models, and thanks for your attention.